Welcome to Bullet Point Nursing. My name is Dr. Goldstein. Let's get started. Today we're going to start going through some labs, and we're doing this at the nursing fundamentals level. Let's begin with looking at a basic metabolic panel, commonly referred to as a BMP. This gives us 8 different values. It checks our potassium, sodium, chloride, bicarbonate, blood urea nitrogen, commonly referred to as a BUN, creatinine, glucose, and calcium. A BMP is sometimes used, and otherwise commonly used is a CMP, or a complete metabolic panel. A CMP includes everything from the basic metabolic panel, plus it checks a few other things, mostly related to the liver, including the ALP, ALT, AST, protein, bilirubin, and albumin levels. Let's begin with looking at potassium. A normal potassium is 3.5 to 5 milliequivalents per liter. Hypokalemia is the term for when we have a potassium below 3.5. It is treated with oral or IV potassium, and we talk more about this in pharmacology. A presentation of hypokalemia commonly includes muscle weakness, dysrhythmias, and adverse kidney effects. It can be caused by vomiting, diarrhea, and diuretics, and it is often seen together with hypomagnesemia. Hyperkalemia is the term for an elevated potassium level. This would be treated with patiramir if the patient is stable, or insulin and glucose if the patient is unstable. A presentation for hyperkalemia includes muscle weakness up to paralysis, as well as dysrhythmias up to cardiac arrest. Next, let's look at sodium. A normal range for sodium is 135 to 145 milliequivalents per liter. Volume status must be assessed because this can impact the patient's sodium level. Let's take a second and think about that. If a patient has X amount of sodium in their body, but suddenly they have a ton of fluid, that sodium is going to get diluted down, and their sodium is going to look as if it's really low. Even though their sodium level is normal, it's their fluid level that's really high. And the same thing can happen with the opposite. Hyponatremia is the term for a low sodium level, and that is below 135. Below 120 is generally considered critical. A patient presentation with hyponatremia includes seizures and coma. These must be corrected slowly. Generally, the rule is to not correct someone's sodium greater than 0.5 milliequivalent per liter per hour. What that means is if someone's sodium is at 125 and we're trying to bring it up to 135, we're trying to bring it up 10 points, it should take us at least 20 hours. Hypernatremia is where we have a sodium level above 145, and this is most often related to dehydration. Again, that goes to what we discussed earlier, where if they have a low volume status, now suddenly their sodium looks as if it's really high. Next, we have chloride. Not much to cover on this one. The normal range is 98 to 106. Bicarbonate is next, abbreviated HCO3, and a normal range for that is 23 to 28. You'll see more of this when we learn about ABGs, or arterial blood gases, in med-surg. Bicarbonate is used in combination with CO2 and pH to assess acid-base balance. A low bicarbonate usually indicates acidosis, whereas a high bicarbonate indicates alkalosis. Next, we have our BUN, or blood urea nitrogen. The normal range for this is 8 to 20 milligrams per deciliter. And this is one of the primary labs, along with the next one, for assessing kidney function. The kidney's job, or one of it, is to remove urea from the blood. Therefore, if we have an elevated level of urea, we know that the kidneys are not doing their job. Next, we have creatinine, which is the other primary lab of these to assess for the kidneys. A normal creatinine for females is 0.5 to 1.1, and for males is 0.7 to 1.3 milligrams per deciliter. Again, just like with urea, the kidney's job is to remove creatinine from the blood, and high levels of urea indicate the kidneys are not doing their job. There is a calculated lab that we get from the BUN and the creatinine. It's called the BUN creatinine ratio, and that should be normally around 10 to 1. Next, we have our glucose. A normal range here is 70 to 110 milligrams per deciliter. And it is called hypoglycemia when a patient has a low glucose. Symptoms of this include anxiety, tremors, palpitations, confusion, and more. This may be treated with oral glucose if the patient is stable and can tolerate that, IV glucose otherwise, or if we don't have IV access, then IM glucagon. Hypoglycemia is almost exclusively seen with patients that have diabetes. Hyperglycemia is where a patient has an elevated blood glucose level. A fasting blood glucose above 126 would be considered elevated. A non-fasting above 200 would be considered elevated. You may see some sources that put it at above 180 as abnormal. A healthy patient without diabetes should not, even postprandial, meaning right after a meal, should not have a glucose level above 200. Hyperglycemia is treated per the diabetes clinical practice guidelines, or CPGs, if you're not familiar with that term yet. Next, we have calcium. A normal range is 8.6 to 10.2 milligrams per deciliter. Hypercalcemia is the term for when it gets above 10.2. And the most common causes are hyperparathyroidism and cancer. The vast majority of all cases of hypercalcemia are going to be malignancy related or cancer related. These can also be caused by an excess of vitamin D intake. When a patient has a low calcium, that is hypocalcemia, symptoms of this include muscle spasms, cramps, seizures, and paresthesias. Schwastik sign and Trousseau sign are two assessments that we use for hypocalcemia. And causes of hypocalcemia include a lack of parathyroid hormone and or vitamin D. Thank you for watching. Here are your references. Have a great day.